Hello and welcome to GatherVerse News Unscripted, your home for humanity-centered tech journalism. We are going to be speaking today about an issue that is plaguing many in America, depression, but the hope that comes from a new AI tool. So we're going to be talking with the founder of Ellipses Health, but let me set the stage for you a little bit. Here's what you need to know. First of all, depression rates in the United States are skyrocketing. There was a new Gallup poll out, and shockingly, it shows that 18% of Americans say they've experienced depression or are experiencing depression. That is a record high. We have never seen numbers that are this high before. Second, there is an enormous gap in the number of mental health care professionals available to provide help to people. So, a recent report by the Health and Resources Services Administration said that we need 8,000 more counselors and psychologists in order to bridge this gap. We just don't have enough people who are available to help those who are struggling with mental health issues. So into this breach is stepping a new company with a new artificial intelligence tool. You may have heard about virtual apps or text-based counseling, but this one's a little different. This is an artificial intelligence tool that would work in concert with a counselor to listen to a person's voice and diagnose how depressed they are and to rush the cases of people who need help the most into therapy as quickly as possible. So joining me now is the founder of Ellipses Health and the CEO, Manul Mandal. Manul, thank you so much for being with us here on GatherVerse News Unscripted.
Thank you, Priya. Excited to be here.
So Manul, tell me about how this idea came about for this particular tool that you've created with others.
Look, yeah, exactly. Well, look, it takes 11 years on average to be identified as having anxiety or depression. And over 50% of patients go undiagnosed for mental illness, right? Now, if you sort of break apart the problem, what I saw in my case with my mom, she has severe depression and she was going through our sort of case management conversations. And what made me realize was when you are talking to your frontline workers, your primary care physicians, your care navigators, your case managers, your nurses, right? We're expecting them to do a whole lot more than they can do with the time that they have and the training that they have. So in my mom's case, she was going through a case management conversations. When it came to sort of mental health, it wasn't as quantitative as physical health, right? In physical health, we have a blood pressure cuff, we have a thermometer, we have A1C. For mental health, the best we have had so far is a PHQ-8 and a GAT-7, right? So those assessments, which are not objective, and honestly, a survey can never be, it doesn't show the member and the patient that you care, right? So the assessments are sort of faulty to begin with and not objective to begin with. The assessments that we're expecting our frontline workers to do are not going to be accurate. And if it's not accurate, the triaging is not going to be accurate, right? The entire ecosystem sort of falls apart.
Is there any sort of evaluation out there to show that these are not very effective, the surveys themselves? Because those are generally written and self-reported, right?
Correct. Those are self-reports. Look, I think that this standard measurement of the PHQ-8s and 9s and GAT-7s, depression, anxiety, have been around for a long, long time. And I think that the gold standard is actually a mental health professionals. So our idea of Ellipses is that can we train our algorithm to actually learn how a mental health professional would actually do the assessment, but that's the gold standard and not subjective. And how do we sort of plug that understanding, those models, into a primary care conversation call, in a nursing call, in a case management call? So all of a sudden, you have a mental health professional's way of listening on every single call, which means the assessments are going to be much more objective, much more scalable, and so that we insert that right at the get-go.
So how does this work? Someone calls in to a healthcare hotline, or they call into their doctor's office, and then a robot is listening in. Tell me how this works.
Yeah. So everything is done with permission and consent, right? That's sort of our day one. If you are in healthcare, you just have to be above board on everything you do, right? So when you actually have a virtual appointment, let's say with a primary care physician, you've gone through the consenting process. And when you get on the call with your primary care physician, in this example, or case manager, the voice comes through, right? You have two voices. You have the provider's voice and you have the member's voice, right? So we take away the provider's voice right away. We, meaning the algorithm does, right? No human is touching any of these processes. And then the algorithms actually de-identify the member's voice, right? So no one has an understanding of who this voice belongs to. And every 5 seconds, it actually hits a bunch of algorithms with a probability saying that do we have enough signals to actually do assessments? We meaning the algorithms, right? In about a couple of minutes, 2 3 minutes, it actually lands on the severity of depression, the severity of anxiety with a probability level, right? So all of a sudden, during the call, you have a primary care physician to be able to understand what a member is going through, right? Especially with permission consent that given already, and what to do next, right? So there's no lag. So you're able to sort of do the assessment and triaging of that care right away. So if somebody is flagging for severe depression, you know what to do. The primary care physician will be able to say, hey, look, we have someone in the network. Let's make an appointment now so that you can see the mental professional right away. Because right now you're having to wait sort of a couple of months, 2 3 months for an appointment to happen. And if somebody who's sort of minimal, they don't need to see a psychiatrist, psychologist right away. They can wait a little longer, right? So they go into other sort of wellness tools that's approved by the health system.
So, how are these algorithms trained, Manuel? How do they know if someone is depressed or not?
Yeah, I mean, I think it comes down to sort of data, and any sort of healthcare data is sacred, right? So we've been working on this for 5.5 years with many of the institutions we all know, the Mayo Clinics of the world, the Vanderbilts of the world, other clinical partners, where we have gathered a lot of data with permission and consent. So we've gathered the voice file and the corresponding labels. The labels meaning the PHQ-8, the GAT-7, that's where we started first. And then we've started adding other layers of data. So a mental health specialist, a sort of labeling of a voice. So for example, we've had access to a psychologist conversation with the patient, again, with everything with permission, psychiatrist assessment. So we have put everything together, all these labels like the PHQ-8, GAT-7, the HAM-A, the HAM-D, the mental health professionals labels all together and built our models.
And are you finding that your tests are coming back with the responses you expect? Are they fairly accurate? And how are you measuring that accuracy at this point?
Yeah, so really good question. I mean, I think that we first of all started off with what's the standard now, and how do we sort of rate against those standards, the PHQ-8 and the GAT-7, and then we start looking at how do we sort of rate against a mental health professional standard because that's a gold standard, right? So in what we're about to publish with a client, which is a very well-known sort of health system, in the next 3 months, you're going to see this. In the cases where we have disagreed, our algorithms have disagreed with the PHQ-8 and GAT-7, we actually showed we are as good as a mental health professional's assessment, right? And that's exactly where we need to be to make it objective, to make it sort of think the assessment side the way the mental professional would think.
What sort of an impact would it have into a healthcare system? How much faster will it help triage clients and assess their needs?
Yeah. And I think, Priya, I think you brought up another question as you're asking about the data, and it sort of plugs into this question. Look, America is a very diverse country, right? And one of the things you just asked about the data and how do we sort of proven ourselves to be creating the next standard for mental health. It's about also showing across demographics, right? Do our algorithms work across sort of Asians, South Asians, Caucasians, Hispanics, right? Does it work? And we've shown it works. It's actually the papers on our website across sort of the age groups, right? Does it work on mental health, people who are suffering from mental health as well as general population? Does it work across sort of male and female, right? So all of that we've shown. And the reason why it's a nice segue to your question is that if you're able to sort of triage at the point of encounter, a clinical encounter, you have saved someone in a hyperbolic way, is the 11 years we talked about, right? That's sort of the stat, the 11 years from the time you show sort of symptoms to getting care, that gap shortens, right?
Until you actually
11
get care.
exactly, by a massive, massive, massive amount, right? So all of a sudden, you are saving sort of that time, the hour, and the pain somebody has to go through from those years and years to minutes, right? So you have actually augmenting these healthcare professionals to be able to do more than otherwise they would have able to, because of finite amount of time.
And do you have a sense of how much that time is shortened?
Yeah. So in our case, what you'll see in the publications, about 2 to 3 minutes is what it's going to take. It's passively listening for all the things with permission and consent. And we have two product lines. One is sort of looking at how do we help the frontline workers to be able to do assess, triage, all that stuff. And there's surrounding sort of other products around it, right? How do you sort of help the providers take notes, right? How do you sort of algorithms help you, the providers, understand what is it that the member is struggling with? So for example, if someone is struggling with food insecurity, are there things that they can do now, right? So that's one product line during a live call, not scripted, a live conversation, right? The other one is actually, sorry, any questions?
No, please go ahead.
The other one is actually sort of in between visits. So, for example, I have no idea how my mom did yesterday, right? No clue. She doesn't have a watch or any sort of vitals for mental health. So we have a very sort of a simple voice journaling tool that asks open-ended questions. How are you? How's your week? Things of that sort. And that assessment takes about 45 seconds or so, right? Again, shortening. And it also acts like a therapy, right? And we have
Mm.
seen sort of people open up about their lives, what they're going through, right? And our algorithms are smart enough to be able to say, hey, by the way, can we suggest XYZ? This is based on what we've heard, right? So to be able to sort of get away from a self-reporting reported assessment and not really having a heart, like surveys don't have heart. It doesn't tell you we care, right? It's a task, right? To actually creating sort of humanness in this technology and say, we care, and you're going to see the results in the next 2 3 minutes because we're going to help you connect sort of the next level of care here.
There's a question that came in, which is why I hesitated for a moment, and you picked up on that very quickly. But the question that came in is there a plan to make this accessible to clinics and the like, where uninsured and underinsured people tend to have to go? And I think this gets to the topic of equity access. Because right now in America, often, money talks. And if you can afford to pay for a private therapist, then you get the help. But if you don't have that money, if you can't pay for help independently, then you may be suffering without access to any recourse or relief. Tell me a little bit about how you see your work as at Ellipses Health as lowering those barriers for people who want to get help.
Right. I mean, healthcare should be for all, not for the selected few, right? And most of us have a voice, right? It's an asset we already have, right? So we wanted to sort of give back the power to the members, the patients, people that are going through rough times, whether you are wealthy or whether you're not, right? So that's sort of where our vision was when we started Ellipsis, right? This tool has to be for every single home, right? And by the way, the patients and the members are not paying for it. The health systems are paying for it, right? So the onus, the burden is on health systems because they also benefit from this, right? There's a huge amount of benefit that the providers and the health systems get out of it. And for them, it's about the impact that they're going to see in their patients and how that impacts their bottom line as well. So that's why the genesis of Ellipsis is that using voice, right? And someday in the next few years to be at every single home. Now, we are not a consumer-centric tool yet. Down the road, we will be. But right now, we are starting last year, we've started deploying with some really well-known health systems out there.
You're talking about how it can be a tool for the institutions, and I definitely think I see that. In terms of the patient, the client who comes in and is being diagnosed, what happens when there's a mismatch between how depressed they think they are and what this AI tool says?
Yeah, I mean, so it's assessment. We're not diagnostic yet. So we are on a pathway to be an FDA-approved assessment tool in the next year to 2 years. So I think that if I ask my mom how she's doing, she'll say I'm fine. We all know she's not doing fine. So we've actually found a really sort of interesting way to look at this, how someone speaks and what someone says. So we're the only one in the space that has a fused model, right? So when I talked about hitting a bunch of models, it's looking at how mom is speaking and what she's saying. So she could say I'm fine, right? But how she said it actually makes a huge difference. So both our models are now working almost equally as effectively. And that's how we look at it. And in a given sort of the labeled data set that we have had for years, access that we've trained our models on, including some of the clinical data we have, right? Access to like medication history, things of that sort. The algorithms are smart enough to actually figure out. And that's why we say 2-3 minutes, right? It takes 2-3 minutes to be able to figure out the assessment levels. Um, so it is, if you look at sort of our results that's on our website at what's coming, our algorithms are very, very robust across demographics and gender and other things.
Manul, when it comes to the work that you're doing to try to alleviate the symptoms of depression, to try to get people who need help into help, what is the impact you're hoping to have?
Yeah, I mean, look, early identification is extremely critical, right? For example, take somebody whose A1C is getting, higher and higher and higher, right? If that person had access to say, they my A1C is actually going, escalating. What can we do? Is it my diet? Is it my medication? Right? We have that for physical health, right? So one of the key things we want to actually do is actually how do you reduce sort of the burden of mental health on this world, right? The other one is sort of looking at how do we quantify mental health so people can understand what it is, right? It's been pretty subjective as a field, so we want to sort of make sure that people can have the dialogue and say, hey, this is what I'm going through. Here's my assessments, right? Whether it's gender, across genders, it's race or income level, doesn't matter. Everyone can talk through that. So for us, I think being able to go early as adolescents, right? We're commercial 18 and above. I think next year sometime you'll see Ellipsis Health having a super exciting announcement that I am personally extremely excited about, is going to 11 years and above, right? We have to go early. So imagine how helpful we can be as a society to be able to sort of help someone, a family who's got kids as early as 11.
And so, what are you hoping that will do if you can get to kids when they're even younger? And I have to say that I think while there's a promise, there's also a fear that people have that you're going to be diagnosed by something that is impersonal and that doesn't know you, as opposed to finding ways to improve human contact.
Yeah, I mean, I think for companies like Ellipsis, who is working on something so impactful, you have to always lead with consent and privacy and security. That's just the basics, right? Beyond, I mean, we have to be beyond sort of HIPAA compliant, GDPR compliant, SOC 2 compliant, and all of that, and create trust. And that's why
Mm.
I think that the inherent trust we have with the providers, that's where we're starting. We're starting with not on the consumer side, right? Actually, with health systems people respect. We have, as I was talking about, the clinical partners we have anywhere from Mayo to Vanderbilt to Optum, Highmark Health, right? These are well-known systems people trust, right? So we give the ability for users to be forgotten as well, so they don't have to consent, right? So for us, I think that we have placed, and that was sort of the day one principles for Ellipsis, right? No surprises, transparency, and lead with sort of publications. We are the most peer-reviewed published company in this space by far, right? And we've done things, as I said, talked about, not requiring baseline across sort of the gender and ethnicities and whatnot, right? That's what we had to start with near one, right? So I think that with that kind of principles in place, going early can actually help years and years of agony,
Mm.
right? The kids who have this immense amount of potential. If you look at what's happening in these colleges and the high schools and the middle schools, right? Right? Can we sort of lower that burden? Absolutely. How do we lower that burden? Same analogy as I was doing about A1C. Go early, intervene early. We have a limited number of people who can help us, right? In terms of mental professionals, let them address the ones who need the most help, right? Otherwise, the backlog will never be resolved.
Manul Mandal with Ellipses Health, the CEO and founder, thank you so much for your time today. I appreciate it. Any last words before you go?
No, I think it's just not our company; it's everyone's company. It's one of those companies that everyone should participate in and building and hold us accountable, right? For something like this that can have an impact for every single individual on planet Earth someday. I think we should all help to sort of companies like ourselves to make this better and actually showing how successful we are in terms of clinical impact. It's really, really important. So thank you.
How do you How do you recommend that people reach out and give you that feedback?
My email, my website still has my phone number. I'm very good at responding. So come and schedule conversations with us, and we are
All
very
right,
transparent.
talk to the man himself, it sounds like.
Anytime, you got it.
All right, Manuel and Dahl, thank you again.
Thank you so much, Priya.
All right. And for those of you watching, come on back tomorrow. Raphael Timmons will be joining us on the show tomorrow. We'll be live at noon here on GatherVerse News Unscripted. See you then.